Assalamu alaikum. Glottic insufficiency caused by posterior glottic gaps in cases, for example, of unilateral vocal fold palsy are best managed by arytenoid adduction procedures. These arytenoid adduction procedures are a family or a group of several surgical operations designed to restore the adduction function of a malfunctioning arytenoid in cases, for example, of high vagal paralysis. They include operations such as arytenoid adduction, in which pulling on certain arytenoid muscles by sutures can effect adduction of the arytenoid and closing of a posterior glottic gap, or adduction arytenoidopexy, in which the arytenoid would be fixed in an adducted position by some sutures, or arytenoid implants, in which implants are used to displace the arytenoid into an adducted position, or injection augmentation of the arytenoid cartilage. These family of procedures are usually used complementary to thyroplasty, medialization thyroplasty, in which the anterior part of the vocal fold would be medialized by thyroplasty type 1, or complementary to procedures such as crico-thyroid approximation to restore tension in a paralyzed vocal fold and reposition the arytenoid after being displaced or tilting forward, or in cases of Cricopharyngeus myotomy with some cases of aspiration after vocal fold palsy. In this presentation on the arytenoid adduction procedures, we shall go first on the functional anatomy of the arytenoid cartilage during adduction in particular, followed by the surgical landmarks for these procedures, and then the step-by-step for the arytenoid adduction procedures, in particular the arytenoid adduction operation and arytenoidopexy, and we'll end up discussing the limitations, the results, and risks and possible complications. From this anterior view, you can see the arytenoid cartilage on top of the cricoid ring, with its two prominent processes, the vocal process and the muscular process. To the vocal process that forms the posterior part of the vocal fold is attached the vocal ligament, and just lateral to this would be a part of the thyroarytenoidus muscle, the vocalis muscle, that forms the bulk of the vocal fold. On the muscular process overrides the edge of the cricoid ring. To its anterior part will be inserted the lateral cricoarytenoid muscle. This is the major adductor that closes up the glottis. To the posterior part of the muscular process, seen in this posterior view, would be the insertion of the posterior cricoarytenoid muscle. This is the major abductor of the vocal folds. Between the posterior cricoarytenoid and the anterior cricoarytenoid is a ridge of bare bone covered just by its perichondrium, and this ridge of bone would measure about 10 millimeters, the size of a rice grain, for example. This is an ultrasound scan of the larynx, horizontal axial scan. You can see the thyroid cartilage in here, and you see how the thickness of the thyroid cartilage anteriorly is much less than its thickness posteriorly. Anteriorly it measures less than 3 millimeters, and posteriorly it measures about 5 millimeters or so. You see here the arytenoid cartilages with its muscular process laterally and the vocal process medially. You see the vocalis muscle, the dark muscle in here, and just lateral to it you would see the lateral cricoarytenoid going from the muscular process of the arytenoid towards its insertion in the cricoid. This is the major adductor of the vocal fold. Posterior to the muscular process would be the posterior cricoarytenoid covered by the pharyngeal mucosa. The piriform sinus would be here somewhere. The original older versions of arytenoid surgery approached the arytenoid by removing the posterior part of the thyroid ala, and that gave a direct access, wide access to the arytenoid. the modern keyhole techniques would approach the arytenoid cartilage, the muscular process, and the lateral cricoarytenoid through a small window, a tiny window created in the thyroid cartilage at this area just in front of the oblique line of the thyroid. We see here three surgical approaches to the arytenoid cartilage for adduction procedures, all related to the thyroid ala. In the original version of these operations, the approach was posterior approach. This is a lateral view of the larynx with the thyroid ala here. You could see the posterior cricoarytenoid muscle, and you can see the muscular process of the arytenoid here. And the approach entails incising the muscle that covers this area. This is the inferior part of the Thyropharyngeus muscle, and this is followed by removal of a part of the posterior lamina of the thyroid, and this would expose the muscular process of the arytenoid, and through this approach you could work on the muscular process to achieve adduction. Alternatively, this is a front view of a splitted larynx, a splitted thyroid ala. The thyroid ala was incised here on one side, few millimeters away from the anterior edge of the ala, and once it is incised, it's reflected laterally, and this would expose the paraglottic space, and after some dissection you could see the arytenoid in here posteriorly and inferiorly with its muscular process, and you can attach sutures on this muscular process in the direction of the thyroarytenoid muscle or the direction of the cricoarytenoid muscle. But this is an anterior lateral approach to the arytenoid in contrast to the posterior approach here. The third approach is through a keyhole, a small window created in the thyroid ala, in the posterior part of the thyroid ala, just in front of the oblique line of the thyroid. And through this window you can gain direct access to the muscular process of the arytenoid without having to remove any big parts of the thyroid ala itself. This rectangle would mark the anterior window created for type 1 thyroplasty medialization procedure. To gain access to the muscular process of the arytenoid, you need to place a square window posterior to this rectangle window. Both windows would have their upper edge as the mid-horizontal line created from identifying the midpoint between the lower part of the thyroid notch and here, the lower edge of the thyroid cartilage and the midline in here. This line would usually measure about 20 to 24 millimeters in males and 16 to 20 millimeters in females. And a horizontal line through this point usually runs parallel to the lower edge of the thyroid cartilage, would intersect with the oblique thyroid line at a point, and this point would mark the surface landmark of the muscular process in all females and 85% of the males. There will be a little bit variations, about in 15% of the males, sometimes just above this point, but usually just below it. Where to place this tiny window in the thyroid cartilage, the midpoint between the lower part of the thyroid notch and the inferior edge of the thyroid cartilage in the midline is marked, and from which a horizontal line is drawn to intersect with the oblique line of the thyroid. The attachment of the strap muscles will be to this oblique line of the thyroid cartilage, and this would form the upper edge of the window. From the oblique line you would go 8 to 10 millimeters ventrally. This would be the anterior edge of the window, and from this line you would go again 8 to 10 millimeters. This will form the caudal end of the window, and the base of the window will be the oblique line itself. You don't want to go too much posteriorly because the piriform sinus mucosa would be lying here to avoid any penetration of the pharyngeal mucosa. How deep is the muscular process from the surface of the thyroid ala? About 10 millimeters. Usually the thickness of the thyroid ala cartilage at this point posteriorly is about 5 millimeters, and a further 5 millimeters dissection in the paraglottic space would identify the muscular process of the arytenoid in here. So the muscular process is 5 millimeters from the inner table of the thyroid cartilage and about 1 centimeter from the surface of the thyroid ala. And through this tiny window in the thyroid ala that measures about 10 millimeters by 10 millimeters, you can gain access to the lateral part of the paraglottic space and identify the muscular process of the arytenoid in here. To it is inserted the lateral crico-arytenoid muscle. You can also notice here the fibers of the thyroarytenoid muscles inserted into the arytenoid. The posterior part of the muscular process is covered by the mucosa of the piriform sinus in here. That's why we cannot notice the fibers of the posterior cricoarytenoid until the mucosa of the piriform sinus is peeled off carefully to expose the insertion of the posterior cricoarytenoid to the posterior part of the muscular process. And this is a magnified view after peeling off of the piriform sinus, identifying the muscular process in here, fibers of the posterior cricoarytenoid and the lateral cricoarytenoid and the thyroarytenoid muscles. And this arrow would mark where sutures can be placed in order to rotate the muscular process forwards and medially to affect a good vocal fold closure. Another way to check for the position of the muscular process from posteriorly is to mark the midpoint between the root of the superior cornu and the root of the inferior cornu, not the tip, just the root of the cornus in here. And the midpoint should correspond to the position of the muscular process of the arytenoid through which a suture has been placed in here. Three important structures come quite close to the muscular process of the arytenoid and has to be identified and avoided in this type of surgery. The first is the recurrent laryngeal nerve, which the recurrent laryngeal nerve courses from outside the larynx deep to the crico-thyroid joint in here to form the inferior laryngeal nerve in there. It crosses the fibers of the posterior cricoarytenoid and will be quite close to the posterior part of the muscular process of the arytenoid. The second important structure is the mucosa of the piriform sinus. As you can see, the piriform sinus lies just lateral to the arytenoid cartilage in here. We approach the arytenoid cartilage through a window in the thyroid cartilage through this direction in here, and the piriform sinus would be just posterior to our line of approach. You can see it in the posterior part of the created window. Just posterior to the muscular process, you will find the mucosa of the piriform sinus in here, covering the fibers of the posterior cricoarytenoid muscle. The posterior cricoarytenoid muscle would be inserted in the back part of the muscular process in here and will be covered by the piriform sinus mucosa. The third structure is an artery, the descending branch of the posterior branches of the superior laryngeal artery. The superior laryngeal artery is itself a branch of the superior thyroid artery after it perforates the thyrohyoid membrane. It gives anterior branches and posterior branches. One of the posterior branches is a descending branch that crosses the lateral cricoarytenoid outer surface. So it comes into the field. Our window would be somewhere here, and it's important to identify and protect this branch to avoid troublesome bleeding that can be difficult to control through a tiny window.
Arytenoid adduction procedures would be indicated mostly in cases of a large posterior glottic gap usually due to a high vagal nerve paralysis. This posterior gap would not be addressed well with a medialization thyroplasty type 1. Or in cases of unequal level of vocal folds, vertical level of the vocal folds. Again, this will be addressed better by arytenoid adduction procedures. Or in cases of marked malrotation or asymmetric rotation of the arytenoid cartilage, when the arytenoid cartilage is tilted forward or malrotated. Or in cases of vocal fold palsy or glottic insufficiency associated with some respiration due to a posterior glottic insufficiency in this area, or in cases in which thyroplasty type 1 was tried but failed to improve the patient's symptoms, and in some cases of crico-arytenoid joint fixation due to diseases like rheumatic diseases, for example, or post-traumatic fixation of the joint when the arytenoids is not working, when the crico-arytenoid joint itself is fixed and not working well, and in some cases of laryngeal trauma associated with displacement of the arytenoid or fixation of the crico-arytenoid joint. But the prime indication for this type of operation is this poor closure of the posterior glottic gap. This posterior glottic gap is not addressed well with other techniques, including type 1 thyroplasty. In these cases, arytenoid adduction procedures would offer a much better technique for effective posterior glottic closure and better functioning in terms of aerodynamics outcomes and better voice perception as well. And these are the three main surgical approaches to the arytenoid muscular process. The older version was the posterior the approach to the muscular process around the posterior edge of the thyroid ala, or after removing a part, a posterior third of the thyroid ala, and then peeling off the piriform fossa mucosa and reaching for the muscular process. This is the posterior approach. Or the anterior approach, in which the thyroid ala is splitted and reflected laterally to expose the paraglottic space. The approach would be from anterior and lateral through this direction, and after dissection of the paraglottic space for about 5 millimeters or so, you should be able to identify the muscular process of the arytenoid, usually in the inferior and posterior part of the exposed paraglottic space, or through a keyhole window. This window will be placed somewhere here in front of the oblique line of the thyroid, and again dissection for about 5 millimeters in the paraglottic space would get you to the muscular process of the arytenoid directly, and this would allow manipulation of the muscles of the muscular process with no need to remove any big parts of the thyroid ala. With either the anterior or the posterior approaches, the thyroid cartilage will be freed from the internal perichondrium in here, and then dissection of the paraglottic space for about 5 millimeters, and this would expose the muscular process of the arytenoid, and you can see a suture being passed into the muscular process in here, and this suture will be passed at least twice, sometimes more, into the muscular process to secure it in position. The suture line is usually a 3O proline or other non-absorbable sutures. So either you approach it through the anterior approach like here, or you could approach it after removing this piece of cartilage and exposing the muscular process, and then inserting the suture into the muscular process. And then the suture will be passed forward into the thyroid cartilage, few millimeters from its anterior edge, in the direction of the vector between the thyroarytenoid and the lateral cricoarytenoid. And pulling on this suture would therefore pull forward the muscular process and medially, and this is going to rotate the vocal process of the arytenoid medially. Once the square window has been created in the thyroid ala, the inner perichondrium can be incised and careful dissection of the lateral part of the paraglottic space, connective tissue and fat will be undertaken. This will expose the muscle fibers. The horizontal muscle fibers going from posterior to anterior are those of the thyroarytenoidus muscle. The oblique muscle fibers will be going from posterior superior to anterior inferior are those of the lateral cricoarytenoid attached to the muscular process tip. The fibers of the posterior cricoarytenoid muscle will be covered by the mucosa of the piriform sinus, and if exposure of these muscle fibers are required, the mucosa of the piriform sinus would have to be carefully peeled off the muscular process. Notice the change in the direction of the muscle fibers of the adductors of the vocal fold. If the procedure is carried out for adduction of a paralyzed vocal fold, then sutures along the muscle fibers of the thyroarytenoids can be placed. This suture from the muscular process towards the thyroid cartilage would mimic the action of the thyroarytenoidus, and from the muscular process to the cricoid would mimic the action of the lateral cricoarytenoid muscle.
In the original description, Ishiki described this arytenoid adduction procedure and used the suture line to mimic the action of both the thyroarytenoidus and the lateral cricoarytenoid. The suture ends will be placed on the muscular process here and brought out through the thyroid ala about 8 millimeters from its anterior edge, but towards its inferior part. So it will be pulling in the direction of the vector of two muscles, the thyroarytenoidus and the lateral cricoarytenoid. This was the original Ishiki description. He also advised disarticulation of the cricoarytenoid joint to ease in this forward pull of the muscular process, or alternatively cutting out of the fibers of the posterior cricoarytenoid. This will be the opposing fibers to the direction of the pull. These steps are no longer part of the operation. The disarticulation of the cricoarytenoid joint or the cutting of the posterior cricoarytenoid are no longer being used. And then came a suggestion for a modification by Haji, who suggested pulling the suture line in the direction of the cricoid rather than the thyroid ala. The original Ishiki description was arytenoid thyroid ala suture, and this would mimic the action of both the thyroarytenoidus and the lateral cricoarytenoid. In the Haji modification, he would suggest pulling the suture line towards the cricoid and tying it around the cricoid from the muscular process, and this would mimic only the action of the lateral cricoarytenoid muscle. This is the major adductor of the vocal fold. The next operation is the adduction arytenopexy. This operation is different. You are not pulling on muscles to rotate the arytenoid into the adducted position. Here we are actually fixing the whole of the arytenoid in one single position over the cricoid plate. This operation is suitable for arytenoids that are malrotated or displaced forward, or in fixation of the joint by diseases. In this operation, you open up the cricoarytenoid joint, and then through the posterior cricoid plate, a suture is passed, again a 3/0 Prolene or so, a non-absorbable suture, through the posterior cricoid plate, through the opened up joint, cricoarytenoid joint, into the body of the arytenoid, not the muscular process, the body itself, loop it around the arytenoid, retrieve it backwards into the facet of the cricoarytenoid joint, and then through the posterior plate of the cricoid. And when the suture is tied, the arytenoid cartilage will be displaced backwards posteriorly a little bit. This is going to stretch the vocal fold, but also you would rotate the arytenoid into the adducted position,
close up a posterior gap and put some tension into the paralyzed vocal fold. But the position would be fixed. It's not going to be along the vector of the adductors. The cartilage itself will be fixed to the cricoid plate. You would expect a longer vocal fold with a little bit more tension in it that is going to help with the voice and would also close up any posterior glottic gap. The third operation is using a certain implant, thyroplasty implant, with a tail-like projection. The usual implant used for thyroplasty would medialize the anterior two-thirds of the vocal fold, the membranous part. But if you have also a tail-like posterior projection of this implant, it would displace the posterior part of the glottis formed by the arytenoid cartilage medially as well. It would not going to reposition the arytenoid in the correct adducting position. It's not going to stretch the vocal fold because the arytenoid would not be displaced posteriorly medially. It will be just displaced medially, but it may help in closing a small posterior glottic gap. And it is just a small complementary tail-like projection on top of the original silastic block or a prosthesis that is used for thyroplasty type 1 medialization. A less invasive technique that can be used through microlaryngosurgery is the crico-arytenoid implant, in which a small pocket is fashioned in the posterior part of the cricoarytenoid joint. This would be the hypopharyngeal mucosa, small pocket in here, and then a small implant in the form of a stainless steel rod about 8 millimeters would be introduced into this small pocket to displace the arytenoid medially and forward, and then the pocket would be closed by glue. And this would help in maintaining a more medialized position of the arytenoid cartilage and help in closing the posterior glottic gap, a less invasive procedure. And now to the results. Usually the reported results are those of combined procedures, thyroplasty type 1 plus the arytenoid adduction procedure itself. So it's difficult to tell the pure results of the operation on its own, but generally it gives a reliable improvement in the posterior glottic closure and improves some very important indices for voice, like the maximum phonation time, and also subjectively patients would score much better on the voice handicap index after this operation. For example, the maximum phonation time would be almost more than doubled after this operation, closer to the normal levels, and also the voice handicap index would drop very significantly from a mean of about 71 to just about 13 or so within 3 months of the operation. And the success rates are durable. Usually within few weeks the patient would notice improvement in their voice, sometimes up to 3 months. The maximum improvement would be somewhere between 3 and 12 months, and this would last in long-term follow-up for years afterwards. So it's a durable success rates. On the other hand, the complications rate for these operations are generally a bit more than those for thyroplasty type 1. The major or the serious complications are rare and often are due to airway compromise. And this is usually due to edema or hematoma over the arytenoid or tilting of the arytenoid forward. And few rare cases, it would require intervention in the form of either intubation or emergency tracheostomy. If the sutures are too tight, they may displace the arytenoid anteriorly, and few cases there were reported perforation of the biform sinus mucosa. The moderate complications are less frequent, and these are persistent aspiration or dysphagia. Usually this is transient. Once the edema over the operative site settles, it improves, and it can persist in a minority of cases and may sometimes require some intervention. Minor or late complications include things like wound problems, either hematoma or an infection, or the vocal process granuloma, if the vocal process of the arytenoid becomes very stretched under the mucoperichondrium or the mucosa of the vocal fold, a granuloma may form, and sometimes there is a need for revision surgery for this, but the revision surgery rate is quite low, less than 1%. And this table would summarize the success rates and complication rates for some recent big studies, recent from 2023 or 2021 or 2024 for these last two. A big series, or several hundreds, but not all of them had only arytenoid adduction. Some had also other operations like thyroplasty, and some have in addition modified arytenoid adduction through a small window, and some have also arytenopexy and crico-thyroid subluxation. And the success rates are generally very good, sometimes ranging around 90% or so, and this would be visual improvement in the posterior gap, or improvement in the maximum phonation time, or patient satisfaction. On the other side, the complication size, this ranged widely. Sometimes it ranged about 14 to 19%, but it was as high as 71% in a big series here. This 71% of the patient had transient airway obstruction, and some of them had stridor, and one of them had a fistula into the hypopharynx, and one had infection. Some series had no major complications, but in others, reported revision surgery was about 14.7 or so, which is quite high. From these results, it was noted that the complications rates are associated with some risk factors. These risk factors are first, a combined procedure would carry more risk for complications. Like if you add to the arytenoid adductions other procedures like thyroplasty or crico-thyroid subluxation, this would increase the possibility of developing complications. There were also risks related to the patient comorbidities, including pulmonary diseases or bleeding tendencies, prior neck surgery with scarring, and there were other group of risk factors related to the surgeon, technical factors, including intraoperative either over or under medialization of the arytenoid, and the suture position itself was important, and the tension in the suture and the type of the suture and the approach, the technique itself, all these were associated with some risks or increased risk for complications. And finally, the bottom line, this is that arytenoid adduction is effective. It works. It works to correct a posterior glottic gap and arytenoid malrotation or malposition. And it produces durable improvement, and improvement both in the voice and also in swallowing if there is some aspiration. And this is objective and subjective by the voice handicap index or the maximum phonation time or visual inspection of the larynx. Complications can be uncommon, but include potentially serious airway events and sometimes need for immediate intervention to secure an airway. And the best outcomes were those for patients who were properly selected with a large posterior glottic gap or arytenoid asymmetry, and
that AA is usually combined with another medialization procedure if needed, like a thyroplasty, and that a surgeon technique and the sutures are actually important in avoiding complications and bringing about appropriate results. These procedures are technically more demanding and time-consuming than thyroplasty type 1, but have a higher incidence of complications. But they are essential. They are an essential adjunct to the medialization thyroplasty operation if there is a need to it in a posterior glottic gap or an arytenoid mal rotation or mal placement. By this, we come to the end of this presentation on the 3 surgical approaches to arytenoid adduction procedures. Assalamu alaikum.